Thank you, moderator, Dr. Shanmugavel, sir. Thank you, GVK, sir, for the opportunity. So I think you and Dr. Kannan has made my job easy, like to give you an introduction to what is this diabesity. It's not a new term, like it's in fact it's a old term, like almost way back in 1970s, like a gentleman called Ethan Sims. He used this terminology to find out the complex interplay between the excess body fat and the new onset of diabetes or complications of diabetes. So that's how he has done a lot of work on the thing, and he introduced the term diabesity. Of course, like many people, they may get a bit confused with what is this metabolic syndrome and diabesity. Diabesity is nothing but like when the occurrence of obesity in diabetic individual, we call it as a diabesity, whereas the constellation of the other things, like say for example, patient with the central obesity, visceral adiposity, and hypertension, increased triglyceride, decreased HDL, all these things like we grouped under the terminology metabolic syndrome. We know that later, like this diabesity is the link is anyway. I'm going to dwell on the how they are interlinked, and there are many pathophysiological mechanisms, mainly around the insulin resistant and hyperinsulinemia. So it's a big challenge for all of us. Like so, the statistics say that like almost 3/4 of our all the diabetic patients are either overweight or obese. And it's a big challenging thing like which all of us are facing, and each contributes to each one another, and in fact the diabetes and overweight in patients with diabetes, it can contribute to the more and more rise of diabetes. So whenever somebody is having a diabetes with obesity, we say that like my father is a diabetic, my mother is a diabetic, and so something like that, like we used to say put the blame on genetic factors. But in fact, like the genetic factors are the one which gets amplified by the obesogenic environmental factors. That is overnutrition, that's what we are all doing, and physical inactivity, and behavioral problems like sleep disturbances and so on. The fundamental thing cause for the obesity is whenever there is an imbalance between the calorie intake and expended. So that is a very basic fundamental thing which we all know that. Like so globally there is a trend among the youngsters, like even among the middle-aged people, like they do have erratic food habits, and taking energy-dense food and physical inactivity is becoming a very common problem, particularly due to the affluence, like and urbanization. Professor Shashank Joshi used to call is that we are suffering from affluenza. So that's what he usually jovially call this. And recently published the ICMR INDAB study has projected some alarming figures, saying that like almost more than 60 to 65% of our populations are having either diabetes or obesity. So that's a very alarming projection. This is a bit old one, like, but it's worth recollecting that like most of our diabetics are either overweight or obese. So almost 2/3 of our patients are having this problem. We all know that like there is an entity called Asian Indian phenotype, which phenotypically which makes a person to develop some kind of complications, which we all know. Like we have been talking about this, the thrifty genotype and Asian Indian phenotype for all our diabetic patients, which is mainly characterized by less muscle mass and generalized fat deposition, particularly more among the around the viscera. We call it a central body obesity, and it is shown by the increase in the waist circumference and waist hip ratio. That's at the bedside we usually do to find out this. That's a very important thing, but I'm going to project one slide like to find out the importance of this, how each things can influence each other. So we all know that like every 1 kilogram weight gain, Gauri Pata, raises the diabetic risk by 4.5%. Just imagine a person gains a weight of 1 kg, the diabetes risk goes by 4.5. So we all talk about the diabetes control, the holistic approach, and diabetic care, diabetic education, and so on, just to bring down the HbA1c. Say, if a person gains 3 kgs of weight, it can offset the benefits of 1% HbA1c reduction in terms of the qualitative life of the individual concerned. So every 3 kg weight gain can offset 1% HbA1c reduction in our diabetics. So this fact, it's a very simple statistics to remember, but it's worth remembering how the obesity can influence the life of our diabetics. So this is a very common slide, most of you would have seen, like how the interplay between the diabetes and obesity. So both of them have got the almost similar kind of apart from the genetic factor, the similar kind of the influences, say for example, the epigenetics, the circadian clock genes, ROS, reactive oxygen species, inflammation, and all these things put together can contribute to the, both of them are involved in the generation of oxidative stress, insulin resistant, and can invoke a prothrombotic or pro-atherogenic scenario, of course with the elevation of the cytokines and inflammatory markers. So we all talk about the circadian clock genes. They are nothing but like these are all the genomic material that can modulate the proteins in the hypothalamus, so that each the sleep pattern and the circadian, our body runs in a circadian fashion. We all know that, like so these things are being influenced by the clock genes, and this gets modified in the presence of excess hyperglycemia, and as well as the adipocyte dysfunction leading on to a inflammatory milieu. So we all know that like epigenetics, again it plays a very important role in the formation of modulation of this miRNA, microRNA, and the reactive oxygen species. We all know that not only the generation of the reactive oxygen species, please remember that our defense mechanism also goes down with obesity and diabetes. Say for example, superoxide dismutase or glutathione peroxidase level goes down in patients with diabetes and obesity. Of course, diabetes and obesity both have a low-grade inflammatory state throughout their life. So that is one thing which we need to remember. As a result, like we get the cardiac involvement, coronary involvement, cardiac myocytes, your endothelium, and of course it can affect the pancreas and the liver. Of course, we all know that it's a fatty liver. I told you that like genetic factors have a small influence. So I just, it's a big chapter, but I just wanted to give only 2 messages. The thing is, the genetics play almost 40 to 85, it's all individualized. So it depends on the genetic makeup of the individual. It can contribute to almost 40 to 85% of the body fat distribution, number 1. Number 2 is the risk of obesity in children is 2.5 to 4 times high in a single parent. If my parent, my father is obese, like my risk of developing obesity is 2.5 to 4. Suppose if both the parents are obese, then my risk is like almost 10-fold. So that is a very simple thing, analogy, which can be translated to our clinical practice also. Very rarely we come across sometimes like the obesity, diabetes related symptoms. So very rarely, only in tertiary care setup we do see some of the Prader-Willi, Alström syndrome, Carpenter syndrome, all these things. Sometimes we present some of the intensive cases also. So this is main, like this is the most important, not only for the obesity but also for the diabetes also. So the energy consumption, it not that like somebody is taking some energy dense food or something like that. It's not so. So it can result in havoc of the harmony of the hormones. So that's what it does. Like I just brief you tell again, it's again big chapter by itself. Like there are 2 things like measures, the homeostatic and the hedonic are the 2 pathways which can control the energy intake. Of course, homeostatic system stimulates the appetite, and it can also stimulate the hypothalamus and sends signals to secrete insulin, leptin, and it sends vagal afferent also gets excited. Whereas hedonic pathway is a mediator of the rewarding aspects of the food intake. So these 2 things are very complex, but little bit we need to know what actually it is. And the high energy, consumption of high energy, high calorie food also results in low serotonin. So that is more important. Low serotonin also in turn like it can make one to consume more food. And in fact, as the patient consumes more energy dense food, they also get more ghrelin also it's secreted. We all know that it's a hunger hormone. Like so that like they will have more hunger also. That's why people who have the desire to take food, they'll have more desire. Like so that's the reason, like because of the ghrelin. And of course, there are certain hormones, like when you have ghrelin, you have some anti-ghrelin hormone also, like anorexic hormones like GLP, peptide YY, cholecystokinase, all these things are reduced in patients with obesity. So that's why it's not a simple, a patient takes a energy dense food, but it also can cause havoc of the harmony of the hormones. So this is a newer thing. We all know that like this also can contribute to the gut microbiota, the changes in the gut microbiota. So a lot has been taught recently. We have been kept learning about the gut microbiota. Of course, with obesity, with diabetes, any non-communicable disease, we do have some evidence to say that these gut microbiota are involved. In general, any non-communicable disease, NCDs. So the low fecal diversity leads to overall obesity, and it can create a low-grade inflammatory state. In fact, some of the bacteria are more in patients with obesity. Say, for example, firmicutes are more and bacteroids are less. And as a result, like you get a low-grade inflammation inside because remember that GIT is one of the largest immunological organ in our body, and it can result in a low-grade inflammatory status, and you have more short-chain fatty acids, more fatty acid oxidation, and further inflammatory milieu, and all these things will go and affect the pancreas. That is the adjacent structure that will go and affect the pancreas, and that can result in beta cell dysfunction. Very simple. Similarly, nowadays we do see a lot of IT people, they are doing shift worker, and they can change the microbiota. Not only the shift working, but sleep, diet, and exposure to light, all these things can. I just wanted to dwell 1 minute on this very important thing, which is not being discussed as a causation of the obesity diabetes in our population. So we all know that like everyone requires at least 6 to 9 hours of good sleep, uninterrupted sleep. It's a restorative process for the good health, like we all know that. But remember that like any short sleep, like or fragmentation of the sleep can lead to obesity. That is number one. And how does this happen? Like sleep deprivation can cause reduced levels of, again, the hormones like leptin and increased levels of ghrelin, and that will offset the satiety balance. And not only, who are all the people who are at risk of developing these sleep disturbances? People who does the night shift, jet lag, people nowadays, they glue to the cell phone or computer or something like that till 2 a.m. in the midnight. The screen time, the more the screen time, the exposure to the light, to the retina, all these things, patients with obstructive sleep apnea, restless leg syndrome, all these patients can have a sleep deprivation, eventually land up with unknowingly. They may not know that like it can contribute to the genesis of the diabetes and obesity. And what happens when somebody is having a sleep deprivation? They have increased parasympathetic activity to the viscera, and more importantly, they'll have more sympathetic activity to heart and vasoconstriction. That's why people who do not sleep, they are at risk of developing more CV, mortality and morbidity. That's a very simple thing. Again, we have understood during our physiology. And sleep deprivation can change the person's the food choice of food. So that's one has to understand, not the habit kind of thing. The unhealthy food type choice is also being changed. Even with duration of 6 days of sleep deprivation, it can result in all these changes. Of course, the cortisol levels also goes up in patients with sleep deprivation, and which can again lead on to the development of insulin resistance and so on. I just take you to another few slides to explain what does this hypothalamus, in fact, it does. Like we all know that like it's a vicious cycle. It contributes to each other. So the diets high in the long chain, short chain, saturated, long chain fatty acids, and obesity can cause profound changes in the energy balance by altering the signals from the hypothalamus. How does it happen? That is mainly because of the signals to leptin, and you have hyperleptinemia, and in fact you have leptin resistance also. And what does this leptin does to our body? It is associated with the fat mass and regulates the food energy and energy intake and energy consumption. And it can also, this hyperleptinemia is harmful, just like insulin resistant hyperinsulinemia. Hyperleptinemia is also harmful to our tissues, particularly it can contribute to the skeletal resistance. We all know that like if somebody can develop a skeletal resistance, the adipocytes, fat tissues, liver, or in the skeletal muscle. But once you develop all these things, you can also can have a ectopic fat deposition in other organs. Say for example, the organ which usually does not store fat in our body, say for example heart, say for example your kidney, say for example your the other endocrine organs. So all these things which never stores in the body usually, so they also stores body and they develop insulin resistance. So this is another concept like the adipose tissue dysfunction, like we all know that, like how I already alluded to. So what does this adipose tissue does to our body? It creates a very simple, it's a bit crowded slide, but I tell you, like, it can create a low-grade inflammatory state, and it's a vicious cycle, okay? So this is very important. So the obesity and adiposopathy, like, so all these things can result in the immunopathies and the endocrinopathies, what we see nowadays. So after the COVID, like we do see, like there is a huge surge in the cases of overweight and obese population in our community. And all these things can contribute to there is a crosstalk between whenever somebody is having excess fat like adipocytes, it can go for, once it goes for hypertrophy, it can get some kind of dysregulation. And as a result, like it can result in organ dysfunction also when they go on deposit, okay. So this, adipocytes can go and also can deposit in the organs. Say for example, your liver, muscle, pancreas, kidney, heart, and all these things, perivascular tissues, all these things, and can contribute to the significant CV risk. I just to tell you one more thing. So the ectopic fat deposition, in particularly in the pancreatic fat, it can cause the beta cell dysfunction also, and insulin resistance also goes up in patients with any patients with ectopic fat deposition. And recently, there is a joint position statement from the International Atherosclerosis Society says that like visceral adiposity and ectopic fat are emerging as a risk factor for not only for type 2 diabetes, but also for developing atherosclerosis and subsequent cardiovascular disease. So this is my last slide. Like so far, I've told you that like the patient can develop so many conditions wherein they can develop this diabesity, like the occurrence of obesity in patients with diabetes. But all these things can get mitigated by doing a healthy lifestyle, by maintaining a healthy lifestyle. So I think we have listened to Dr. Nandita in the morning about the importance of the diet and so on. But the one thing which I would like to reiterate, being a medical profession in the community, we need to set an example to the community, and persistent, regular physical activity, definitely it can nullify. If you could see this slide, like so you can borrow this slide from me also. This is a very nice slide, like which has shown that like whatever the physiological, pathophysiological changes occurring in our body due to this diabetes and obesity can get mitigated by doing a regular physical activity. That's why we talk about if somebody loses 15% of the body weight, even diabetes can go for remission. So the fat in the liver can goes down, and you get even reversal of fatty liver. All these things we talk because of this very good very good effects of these physical activity. With this, I thank you. Thank you.